Hello guys, in this video I am going to discuss about the medical termination of the pregnancy. This MTP is very important. Everyone should know about the MTP. First, what is MTP? The definition is a willful termination of the pregnancy before the age of fetal viability. The fetal viability is crossing when the fetus is above the 20 or 24 weeks. It depends upon the various in varies in the country. If it is WHO, the fetal viability is 24. In India, it is 20. Okay. MTP Act came in 1971. The amendment is passed on 2021 March. First, the MTP Act came in the 1971. Then some corrections are did, and then they passed again in 2021 March. The incidence of the MTP is 6.7 million annually. Because this incidence, most of the that means 40 to 50% of cases leads to unsafe abortions. The consent, we should get consent from her husband or some other. No, the only female consent is enough. The partner consent is not required. And if the female is less than 18 years and mentally ill, we can get consent from her guardian. Okay. Next, the MTP Act 1971 and 2021. There is a lot of difference between the 1971 and 2021. Most of the examiners asked about the current, that means 2021 amendment criteria. The indication of MTP in 1971 is only for married women, and in 2021 can unmarried women also covered. And gestational age limit is 20 weeks for all indications, but in MTP 24 weeks for rape survivors. Beyond the 24 weeks also done for substantial fetal abnormalities. Here up to 12 weeks one registered medical practitioner is enough. Up to 20 weeks there is a 2 RMP, but here totally altered. 1 RMP is enough for 20 weeks, up to 20 weeks, and 2 RMP is for up to 22 to 24 weeks, and medical board approval after 24 weeks also by 2 RMP. And breach of women's confidentiality means if you break the confidentiality, they should fine up to 1000 rupees. But in 2021, fined and also imprisonment for 1 year. And qualification for doing MTP. Who are all can do MTP? First, the registered medical practitioner who has assisted in 25 MTP, and at least they do 5 or 6 should be a primary surgeon, and RMP who has done 6 months of house job in Obstetrics and Gynaecology and should get diploma or degree in OBG. And indications, there is 4 indications for MTP. One is medical indication, and another one is eugenic, and third is humanitarian, and fourth is socioeconomic. In medical indication, if the pregnancy continued till her 40 weeks, it may danger to her life. For example, in severe hypertension, severe gestational diabetes mellitus, and cardiovascular disease, these things leads to endanger the woman's life. So we have to terminate that pregnancy. In eugenic cases, that means malformed fetus or physical or mental abnormality fetus, it can't survive after the period of viability, or when we enter into the external environment, it can't survive. It may be difficult to that fetus. So that's time we have to terminate by a eugenic manner. And humanitarian means if the woman is raped or incest, we have to terminate. And socioeconomic classes, if the women already have a 4 children and now um, fifth pregnancy is confirmed by the UPT, means she can't give a food and she can't um, things to grow her the fetus. So that's time we have to terminate the pregnancy. Low socioeconomic classes, so she can't affordable some things to that baby. And coming to contraceptive failure, if contraception is used to prevent pregnancy, but unfortunately they get pregnant, means we have to terminate the pregnancy by MTP. And where should MTP done? The place is only hospital established and maintained by the government, and place recognized and approved by the government. Okay. And document, we have to fill the form 1, form 2 and form C. Form C is consent form and admission register. Here now I am going to discuss about the methods of termination of the pregnancy. First, here 6 to 8 weeks of pregnancy means we go for medical abortion or menstrual regulation. If it is 8 to 12 weeks means we go for suction evacuation and medical methods. And 12 to 14 weeks means we go for extra amniotic drugs, intramuscular prostaglandins and vaginal misoprostol. And if it is 14 to 24 weeks, we go for again extra amniotic drugs and vaginal misoprostol. First, the methods of termination of the pregnancy, I am going to divide it into two: first trimester and second trimester. Now I am going to only say about the first trimester. In first trimester, first we have to do try to give a medicine to expel the fetus. That is a medical abortion. The medical abortion is only useful less than 49 days or up to 7 weeks. And second one is menstrual regulation within the 42 days of last menstrual period. And third one is surgical vacuum aspiration done between the 7 to 12 weeks. First, I am going to discuss about the medical abortion. In medical abortion, we can give mifepristone alone, mifepristone and misoprostol, both combined capsules, and methotrexate and misoprostol, and tamoxifen and misoprostol. Okay. Now I am going to see about the each and every drug. Most common drug is mifepristone and misoprostol. Mifepristone RU486. What is RU486? Rousel Claff 486 is laboratory number. RU means the founder name, and the mifepristone is the anti-progesterone, anti-glucocorticoid, anti-androgen, and it is the synthetic steroid 19 nortestosterone. Okay. The only mifepristone we used, it is 83% only effective. When we used with the misoprostol, the effectivity is 95%. What is the mechanism of action of mifepristone? It binds to progesterone receptor and it reduces the endometrial glandular activity and also accelerate and degenerative changes in the endometrium. It leads to sludging of endometrium. Okay. And next is misoprostol. Misoprostol is the synthetic prostaglandin E1. The mechanism of action is it binds to myometrial cell, causes myometrial contraction and expulsion of the tissue, and also it causes ripening of the cervix. The side effects are GI symptoms and Mobius syndrome. The dosage is 200 to 800 microgram every 3 hours. Okay. The contraindication to medical abortion means we have to check IUCD is present or not. Intrauterine contraceptive device. It should be removed before medical termination to avoid perforation. And ectopic pregnancy, we should not give medical abortions. And severe hypertension, gestational diabetes mellitus, asthma, cardiovascular disease, and allergy and seizures. Previous uterine scarring can rupture with misoprostol and fibroid uterus and lactating women because the drugs enter into the lactating that means the drugs enter into the breast milk, and if the woman is a breastfeeder, the drugs also enter into the baby's body. It leads to some other disease into the fetus. And what are the complications? One is adrenal failure, and another one is GIT symptoms, nausea, vomiting, rashes. And third one is Mobius syndrome. What is Mobius syndrome in fetus? That means congenital facial palsy, limb defects, and bladder extrophy, and hydrocephalus. Mobius syndrome means if the woman is pregnant and she get mifepristone or misoprostol drugs for to avoid pregnancy, and the drugs are taken to expel the fetus via MTP. Okay, but incomplete evacuations or incomplete expulsion of the fetus, and the drugs are not so effective. The drugs is not effective, but she continue her pregnancy means the fetus may get this Mobius syndrome. After getting mifepristone or misoprostol, mainly misoprostol, if she get misoprostol to avoid pregnancy, but the failure is happen means she definitely go for evacuation. She not try to continue her pregnancy. Okay. Here, medical abortion protocol in India and WHO. The upper limit is 7 weeks, but in WHO it is 9 weeks. In India, it is done on as a OP patient, and WHO method also on OP inpatient basis. Sorry, here India is it is outpatient, and WHO says it is a inpatient basis. In day 1, we give tablet mifepristone 200 milligram orally. Here WHO said mifepristone 400 milligram orally, and ask the patient to come third day, and we give tablet misoprostol 400 microgram orally, vaginally, or buccal or per rectal, but orally is better comparatively sublingual. Here WHO method said misoprostol 800 milligram as a oral buccal, vaginal, or per rectal, and 15th or 14th day to ensure process completed. That means we do USG to check for any retained placental tissue or any retained placenta, incomplete evacuation, incomplete abortion. And the WHO also says 15 day to ensure the process completed. And any need for USG means no need, or WHO also said no need. We have to just remember this Indian method. It is the outpatient. First day 1, she come to you, and we give tablet mifepristone 200 milligram orally, and ask the patient to come third day we give mifepristone 400 microgram orally, and again checker day 14 or 15, and also we do ESG for any retained or incomplete evacuation or complete evacuation. Okay, next, here you can clearly see this is the combined pack of mifepristone and misoprostol tablets. It is given by the government. Here you can clearly see the single tablet here top is mifepristone 200 microgram. Another 4 is 200 microgram of misoprostol. Sorry, this single one is a mifepristone 200 milligram. Another 4 is 200 microgram of misoprostol. And some other drugs also used. One is gemprost. We can use it as a vaginal Bessari. And another one is carbobrast. This is the prostaglandin F2 alpha analog. And dinoprostate. It is the synthetic prostaglandin E2 intravaginal suppository. Okay. And the next one is menstrual regulation. We have to do within 42 days of last menstrual period. That means aspiration of the content of uterine cavity by means of disposable plastic cannula. The plastic cannula is called Carmen's cannula and used by the 50 ml of syringe. It is more efficient and easy and done in OP procedure and easy to use also. Here you can see this is the 50 ml syringe and this is the Carmen's cannula. Whenever you enter into the gynec theatre, you can see the Garment's cannula. There is a lot of sizes in the Garment's cannula. According to the uterine size, we can use the Garment cannula. Okay. The complication of menstrual regulation means incomplete evacuation, cervical laceration, perforation, infection, hemorrhage. And coming to the in first trimester we can do suction evacuation also. I'm going to tell about it. Wait for it. And in second trimester we do ethacridine lactate and prostaglandin, misoprostol, carboprast, dinoprast, and dilatation and surgical evacuation and intrauterine extraovular instillation of hypertonic saline and oxytocin infusion and hysterectomy in old age people more than 40-50 years and associated with other complications means we go for hysterectomy. First, ethacridine lactate. Mechanism of action is stimulate the endogenous prostaglandin and thromboxane production and promoting the cervical ripening. Okay, to stimulate the prostaglandin and thromboxane. Done on second trimester. The dose is 0.1 solution of ethacridine lactate extraamniotic space through the sterile catheter at the dose of 10 ml per gestational week. The maximum is we can give 150 ml. And coming to intraamniotic saline, it also used in the second trimester MTP. Hypertonic saline 200% used. The dosage is 10 ml per week of gestation. The contraindication is cardiac and renal failures, and complication is hypernatremia and disseminated intravascular coagulation and pulmonary edema. And coming to IV oxytocin, it is also one of the second trimester MTP. The mechanism of action is it stimulates the uterine contraction. The dose is 100 unit per 500 ml of DNS is infused over the 3 hours. And the maximum is 300 units. And coming to surgical method, in first trimester also we can do suction and evacuation by using Carmen's cannula. The number of the Karman's cannula corresponds to the size of the uterus. Okay, the size of the uterus is found by um, uterine sound. That is the one of the instrument we used in the gynec. Whenever you enter into the gynec, you can um, see the what are the instrument in the MTP, that is a uterine sound, Carmen's cannula, manual vacuum aspiration. That's are all things. Okay, and dilate the cervix with the Higgins dilator, and end connected with suction machine, pressure generated 650 mercury. The suction machine connected with electrically means it's more prone for perforation, so we do manually. That is safe for women and also us also. Okay, the end point of the suction is decreased blood loss and gripping sensation, granting sensation, and air bubbles in the cannula. First, in suction evacuation method, first we have. Now I am going to tell again the suction evacuation method by using Carmen's cannula. First, we have to check the uterus size with the help of uterine sound instrument, and it is compared to with Carmen's cannula because to get the corresponding size of the uterus, and we have to dilate the cervix with the help of Higgins dilator, and enter into the enter the Carmen's cannula into the uterus and create a pressure up to 650 mercury. The end point of this suction, we can get the decreased blood loss, gripping sensation, grating sensation, air bubbles in the cannula. We have to remember these three things: gripping, grating, air bubbles. Okay. You can see the manual vacuum aspirator in the end of the apex, means the end of the cones. Here you can see, here we can fix the Carmen's cannula. um, Instead of we can use electricity, we can use the manually with the help of this piston. This is contains a 60 ml syringe. See, manual vacuum aspiration. Here you can see the upper one forceps is Kelly's forceps, sorry, that is Balsalum, or it may be the sponge forceps. And here the lower part is I think it is the Casco speculum, and here is the um, manual vacuum aspiration done using a MBA syringe. MBA means manual vacuum aspiration, done on first trimester. The capacity is 60 ml. The pressure generated is 650 mercury, and this is the OP procedure done on a paracervical block or IV sedation. And dilatation and evacuation done on second trimester. Steps are similar to suction and evacuation till dilation of the cervix. The sponge holding forceps and ovum forceps is used to carry the abortion. Check curettage done, and we have to do curettage. Then only we can see any other fetal parts is present or not. End of the evacuation. And the surgical method is last. Finally, antibiotic prophylaxis has been recommended for surgical abortion, and that is capsule doxycycline 400 mg BD or injection cefotaxime 1 gram IV straight. And if the mother is RH negative, we go for 500 microgram of RH immunoglobulin less than 12 weeks. If it is more than 12 weeks, we go for 300 microgram. Okay. Thank you. If you have any doubts, please comment. I'll try to make rectify your doubts. And in next video, I'm going to post it about the what are all the instruments used in the obstetrics and gynecology. Thank you.